Welcome to all who have joined this second GUPS Virtual Education Series webinar. We're delighted today to present genitourinary pathology educational updates from three outstanding speakers, Dr. Andres Acosta, Dr. Giovanna Giannico, and Dr. Khalil Al-Obeidi. I'm pleased to be joined today by two co-hosts, Dr. Shona Gupta, who is just logging on. Dr. Shona Gupta is just logging on, as well as Dr. Christina Magiguluzzi. And in a moment, we will begin the webinar. I want to alert those who are participating by sharing my screen for a second to be on the lookout for promotional activity around our next virtual education event, which will take place on September 12th. And feature our GUPS Path Presenter Initiative as a teaching case conference with Drs. Preeti Lal, Dr. Sarah Wabker, and Dr. Lara Herrick. And so without further ado, I'm going to introduce Dr. Shona Gupta, who is going to introduce Dr. Andres Acosta for our first talk. Shona, take it away.
Hi, thanks, Samson. So it's a absolute honor to introduce our first speaker, Dr. Andres Acosta. Dr. Acosta attended medical school at the Instituto Universitario Center of Medical Education and Clinical Investigation in Buenos Aires in Argentina. He followed this with residency training at the University of Illinois in Chicago. And he followed this up with fellowships in both genitourinary and surgical pathology at the Brigham and Women's Hospital in Boston. And he currently serves as an assistant professor of pathology at the Brigham and Women's Hospital. Dr. Acosta is extremely prolific and has published on a wide range of topics. And his primary areas of interest are testicular sex cord stromal tumors and germ cell tumors with so-called somatic transformation. And today he's going to talk to us about sex cord stromal tumors. So take it away, Andy.
Andy, please unmute yourself.
Can you hear me? Can you hear me now? Okay, great. Well, thank you very much, Sunak, for that nice introduction, and also thanks for the invitation to speak at this educational series. Today, I'm going to talk about what's new about testicular sex cord stromal tumors, and first we will go over some of the recent changes in the classification of these tumors, and then we will discuss some of the advances that have been made in this field. And because time is limited, I will only provide just a brief summary of the general characteristics of each entity, and then I'll go straight to what's new about them, focusing on emerging molecular data. I have no disclosures for this talk. And a few changes have been introduced in the new WHO classification of sex cord stromal tumors. The first thing that you will notice is that unclassified sex cord stromal tumor has disappeared as a category, and the lesions that were previously classified as such are now distributed between sex cord stromal tumor NOS and mixed sex cord stromal tumors. Another change is that myogonal stromal tumor, which was an emerging entity in the prior classification, has now been promoted to a real entity. And finally, the so-called Sertoli-form cystadenoma of the redi testis is now included under Sertoli cell tumor, assuming that these cases are Sertoli cell tumors that have a predominantly intra-redi growth. So we will start with the updates on Leydig cell tumor, which is the most common type of sex cord stromal tumor and makes up about 2 to 3% of testicular tumors overall. And incidence is biphasic with a small peak in young kids and a larger peak in middle-aged and older adults. The pediatric tumors are often hormonally active and cause precocious pseudopuberty, but in contrast, adult cases more commonly present as a testicular mass, although a subset is hormonally active. 90% of these cases are benign, and the remaining 10% are malignant and metastasized. And this particular subset of malignant cases is very problematic for several reasons. First, because we do not fully understand the molecular events that drive their aggressive behavior. Second, because malignancy cannot always be predicted based on the characteristics of the primary tumor. And finally, because metastatic cases are typically refractory to all types of systemic therapy. And textbook examples of Leydig cell tumors are characterized by solid sheets and nests of neoplastic cells with strongly eosinophilic cytoplasm, round nuclei, and a single conspicuous nucleolus. And ideally, you want to find Reinke crystals because this finding is considered pathognomonic, but unfortunately is not very sensitive. And a study of 3 cases performed more than 20 years ago demonstrated that pediatric Leydig cell tumors are usually driven by a gain of function mutation of the luteinizing hormone receptor that replaces an aspartate with a histidine at position 578 of the protein. In contrast, adult cases are commonly negative for these luteinizing hormone receptor mutation. And a study performed about 16 years ago demonstrated the presence of FH mutations in 2 patients, including one that had a known history of HLRCC. And since then, there has been at least 1 report of a hormonally active adult Leydig cell tumor driven by a hotspot gain of function GNAS mutation. And GNAS codes for the alpha subunit of protein S, which is an upstream effector of the protein kinase A pathway, which is a pathway that is used by the luteinizing hormone receptor for signal transduction. And the same GNAS mutation has also been documented in virilizing ovarian Leydig cell tumors. And in recent years, 2 studies of metastatic sex-core stromal tumors used next-generation sequencing to interrogate 10 Leydig cell tumors each. And these studies found that Leydig cell tumors have a low mutational burden overall and recurrent MDM2 amplifications in up to 50% of the cases. And also pathogenic beta-catenin mutations that before the studies were published had been classically associated with Sertoli cell tumors rather than with Leydig cell tumors were identified in 2 cases in each series. And in one of the studies, MDM2 amplifications were corroborated by FISH. And also in that same study, the authors demonstrated that MDM2 amplifications usually correlated very well with MDM2 overexpression by immunohistochemistry, suggesting that this IHC could be useful to identify potentially aggressive cases. And another recent study that included metastatic cases demonstrated that a subset of malignant Leydig cell tumors have recurrent third exon 2 fusions with different partner genes. And this study also found beta-catenin mutations in 2 primary Leydig cell tumors, confirming that these mutations can be found in this tumor type. And last year, our current GU fellow published a comparative study of aggressive and non-aggressive Leydig cell tumors. The aggressive tumors were either metastatic tumors or primaries that had 2 or more worrisome histopathologic findings. And the non-aggressive cases were, of course, all primary tumors that had either 0 or just 1 worrisome histopathologic features. And in the graph on the right, the aggressive cases are indicated in orange and the non-aggressive cases are indicated in green. And we found that there were 3 molecular subtypes of aggressive tumors. The first one comprised cases with pathogenic FH variants and or evidence of functional FH inactivation using IHC. The second group included cases with gain of function beta-catenin mutations or biallelic APC inactivation that resulted in WNT pathway activation. And the third group had no recurrent mutations. However, they have multiple large copy number changes involving chromosomal arms or whole chromosomes that were consistent with a high degree of aneuploidy, and a subset of these cases had MDM2 amplifications. And the non-aggressive Leydig cell tumors had either no findings at all or only beta-catenin exon 3 mutations, and a subset of these cases that had beta-catenin mutations also had concurrent loss of the long arm of chromosome 22. And immunohistochemistry was a very good surrogate marker of FH inactivation in these cases. In these pictures, you can see one of the FH deficient Leydig cell tumors from our study, and the IHC on the right illustrates the absence of FH expression in the tumor cells with retained expression in capillaries. And here's another FH deficient Leydig cell tumor from our study as well. This one with more significant cytologic atypia. And again, you can see complete loss of FH expression in the tumor cells with retained expression in vascular structures. And this is another case from our study that illustrates the patchy or focal nuclear staining pattern that we saw in the beta-catenin mutant cases. And this correlated quite well with the molecular findings, since the variant allele fraction of the beta-catenin mutations that we found were often suggestive of a subclonal distribution. And in contrast, Sertoli cell tumors often demonstrate, when they are positive for beta-catenin, they often demonstrate diffuse nuclear expression of the marker pretty much in every tumor cell. And I must clarify that while this is true for most cases, we did have some Leydig cell tumors in our series that were more diffusely positive for beta-catenin, and we have seen Sertoli cell tumors that are more, they have a more patchy or focal expression pattern. And in terms of what's new with prognostication of Leydig cell tumors, Maurizio Colecchia recently proposed a point-based system to predict the risk of malignancy in these tumors. This system assigns 0, 1, or 2 points for mitosis and tumor size, which are organized as ordinal variables, and 1 point for necrosis, infiltrative growth, or LVI when these features are present. And in this study, the authors demonstrated that a cutoff of 4 points correctly identified metastatic cases, while purportedly benign tumors consistently scored 3 or less. This method seems to be quite simple, and I think it's promising and can be used in clinical practice, of course, pending further validation. Next is the new kid on the block, a myogonadal stromal tumor. This tumor was described for the first time more than 20 years ago, and it was considered an emerging entity in the prior classification. Myogonadal stromal tumor typically presents in young to middle-aged adults and appears to be invariably benign based on the cases that have been published so far. And by definition, these are pure spindle cell tumors that have co-expression of SMA and S100. Myogonadal stromal tumors are thought to demonstrate a primitive intertubular stromal cell phenotype, and some reported cases had ultrastructural and immunohistochemical evidence of some degree of epithelial differentiation as well. Microscopically, the spindle cells are arranged in fascicles or in storiform structures, and the stroma typically lacks the thick collagen bundles that we find in cases that have been classified as testicular fibromas in the literature. Myogonadal stromal tumors do not have nuclear atypia, but examples with up to 5 mites per 10 high power fields have been reported in the literature. And it is important to recognize that these tumors demonstrate a significant morphologic overlap with fibromas and with adult granulosa cell tumors, as well as with sector stromal tumors in OS. And this typical example of myogonadal stromal tumor has a short fascicular architecture, and it illustrates how these tumors often grow entrapping adjacent structures. In this case, it's entrapping the reed testis, but they very commonly entrap seminiferous tubules as well, but destructive growth is not a feature of this lesion. And the immunoprofile of this tumor with diffuse co-expression of SMA and S100 is in context confirmatory of the diagnosis. And a recent study assessed the cases reported in the literature using probabilistic analysis and demonstrated that these tumors have a 1 in 2 chances of demonstrating some degree of epithelial differentiation, with the most sensitive marker being the presence of desmosomes on electron microscopy. And this study also reported 4 new cases, including one that was evaluated with a 50 gene NGS panel, which did not identify any pathogenic mutations. And we have just completed a multi-institutional study that we're currently compiling in a manuscript. Our series comprised myogonadal stromal tumors diagnosed by multiple different uropathologists that were evaluated with DNA sequencing and with a fusion RNA sequencing panel. And we decided to use a separate fusion panel because given the immunophenotypic and morphologic similarities between myogonadal stromal tumor and biphenotypic sinonasal sarcoma, we hypothesized that maybe a subset of these cases could be driven by the same or alternative gene fusion. Unfortunately, in our study, we did not find any gene fusions, and we did not find any highly recurrent mutations either. There were some rare non-recurrent pathogenic mutations, but they seem to be germline in origin for the most part. What we did find, though, is that these tumors have a very consistent pattern of recurrent whole chromosomal gains. This is one of such cases. The baseline here is at the level of chromosome 1, and the recurrent whole chromosome gains that we're seeing in the other cases as well are indicated by the red arrows. Next, we will talk about testicular adult granulosa cell tumor, which is a diagnosis that, in my opinion, is a little bit of a flying pig. This tumor type has several important differences when compared to its ovarian counterpart. It typically presents as a testicular mass in adult men and only rarely produces sex hormones, and between 10 to 20% are malignant and metastasized. The morphologic spectrum of these tumors is very wide and includes cases that have abundant spindle cells, as well as cases with multiple growth patterns that include the microfollicular patterns we call XR bodies that we classically associate with ovarian counterparts of this entity. And an important consideration here again is that these tumors have a significant morphologic overlap with sex-core stromal tumors NOS and with myogonadal-stromal tumors, especially when they have a significant component of spindle cells. These are two examples of tumors that were diagnosed as adult granulosa cell tumors by uropathologists. And these cases typically have small to intermediate sized cells with high NC ratios and irregular nuclei with nuclear groups, which is a feature that we see pretty much in all of these cases, at least locally. And when we talk about ovarian adult granulosa cell tumors, these lesions have a very specific gain of function FOXL2 variant that changes amino acid residue 134 from cysteine to tryptophan. And in most studies of ovarian adult granulosa cell tumors, this FOXL2 mutation is invariably present in 95 to 97% of the cases. And therefore, in the ovary, this mutation can be considered almost definitory of adult granulosa cell tumors. In contrast, prior studies of testicular adult granulosa cell tumors have found the FOXL2 mutation in only one case, although of course the number of cases analyzed is somewhat limited. So we recently evaluated a multi-institutional series of this entity using next generation sequencing, and we found that adult granulosa cell tumors of the testis are very heterogeneous at the molecular level. In our case, in our series, one of the cases did have the FOXL2 hotspot mutation, but interestingly, while the cellularity of this tumor was well above 90%, the variant allele fraction of the FOXL2 mutation was only 27%, suggesting that it might not have been the primary driver in this tumor. And the only recurrent finding in our study was loss of the long arm of chromosome 2, which was identified in 70% of the cases that sequenced successfully. And although this could potentially represent loss of heterozygosity of a tumor suppressor that's not covered by our panel, I think that, given how common 22q loss is in cancer in general, this most likely represents just a non-specific recurrent finding. And given the molecular and morphologic heterogeneity of these tumors, I think it's valid to at least question if the lesions that we have been classifying as testicular adult granulosa cell tumors truly comprise a defined diagnostic entity. And because granulosa cells are not normally present in the testis, I think that a good starting point to try to answer this question is to see if transformation of Sertoli cells to granulosa cells is possible, at least in theory. And we know from studies of normal development that a peak of WT1 expression in the primitive gonads of XX embryos will trigger expression of R-spondin and beta-catenin. And this results in activation of WNT signaling, and beta-catenin in particular will induce expression of FOXL2, which is the main effector of granulosa cell differentiation. In contrast, in XY embryos, the peak of WT1 expression occurs in the context of SRY co-expression. So in this context, WT1 induces expression of SOX9 instead of beta-catenin, and SOX9 is the main effector of Sertoli cell differentiation. However, There is some experimental evidence that Sertoli and granulosa cells may have some plasticity. And this evidence comes from a model of transgenic mice in which an overactive form of beta-catenin that lacks exon 3 can be induced specifically in Sertoli cells using a promoter that responds to SRY. And in the graph on the left, the white bars represent normal Sertoli cells, the black bars represent normal granulosa cells, and the gray bars represent the Sertoli cells with this expression of overactive beta-catenin. And here you can see that expression of overactive beta-catenin in Sertoli cells reduces the expressions of genes that are normally active in Sertoli cells and increases the expression of genes that are normally active in granulosa cells. And the heat map on the right shows that the gene expression profile of Sertoli cells with this overactive form of beta-catenin is more similar to that of normal granulosa cells than to that of normal Sertoli cells. So at least in theory, events that ultimately lead to activation of FOXL2, such as the FOXL2C134W mutation or beta-catenin mutations, could, in theory, induce a granulosa cell phenotype in Sertoli cells. However, if we define adult granulosa cell tumors of the testis using the ovarian counterparts as a reference, they should have a much higher frequency of the FOXL2C134W mutation. And unfortunately, particular adult granulosa cell tumors with and without this hotspot FOXL2 mutations do not seem to have significant differences based on the limited numbers of cases reported in the literature so far. So therefore, the question is whether we should restrict the diagnosis of adult granulosa cell tumor of the testis to those that have a demonstrated FOXL2C134W mutation and just call the rest sex-core stromal tumors NOS. And in fact, my opinion is that the diagnosis of adult granulosa cell tumors of the testis should be used only rarely, because again, if we use the ovarian adult granulosa cell tumors as a reference, true adult granulosa cell tumors of the testis seem to be vanishingly rare. However, if you're like me and you always buy the cheapest economy class seat available, you may occasionally see a true flying pig. And finally, we will talk about a few advances in large cell calcifying Sertoli cell tumors. This tumor type affects adults and pediatric patients. Most cases are sporadic, but about 20 to 40% present in the context of the Carney complex. And a few cases have also been reported in patients with NF1 and with Poitiers syndrome. But we believe that at least a subset of the cases that have been reported in Poitiers, in the context of Poitiers, probably represent examples of intratubular large cell hyalinizing Sertoli cell neoplasia. And these tumors often present as a testicular mass, but a subset are hormonally active and can have symptoms associated with hormone production, and about 10% are malignant and metastasized. Microscopically, they are characterized by cells with abundant eosinophilic cytoplasms that are arranged in trabeculae, in cords, or that demonstrate solid growth. And typical cases also have this abundant myxoid stroma with a neutrophilic infiltrate and laminated mulberry-like calcifications. And lymphocytic infiltrates and aggregates are also common, especially at the periphery of the tumor. And about 20% of these cases will demonstrate extensive solid growth with little stroma and either sparse calcifications or no calcifications at all. And of course, this subset will have significant morphologic overlap with Leydig cell tumors. And recently, one of our speakers today, Khalil Al-Obeidi and his colleagues, compared the frequency of 6 adverse histopathologic features in cases that they characterize as clinically benign, clinically ambiguous, or clinically malignant. Malignant cases were those with metastasis. Benign cases were those with no evidence of metastasis after a minimum follow-up of 18 months. And ambiguous cases were those without metastasis, but with follow-up periods shorter than 18 months. And this study found that patients with clinically benign disease were younger than patients with ambiguous or malignant tumors. And an important finding here was that 2 clinically malignant cases had no adverse histopathologic findings. And on the right, you can see that most clinically malignant tumors presenting in patients older than 25 years had 2 or more adverse histopathologic findings. And based on their results, they concluded that tumors in patients younger than 25 years without adverse histopathologic features can be probably considered benign, But in contrast, tumors in patients older than 25 years are always worrisome for malignancy, especially if they have one or more of the adverse histopathologic findings mentioned in that slide. And another recent study of this entity was published by our colleague Will Anderson. This study used PRKR1A IHC to demonstrate that functional inactivation of PRKR1A is almost invariably present both in syndromic and in sporadic cases. And in this study, Will also showed that PRKR1A IHC is an excellent tool to distinguish between large cell calcifying Sertoli cell tumor and Sertoli cell tumor NOS or Leydig cell tumor. And finally, before I finish, I'd like to mention two issues that may be important in the field of sex-core stromal tumors of the testis moving forward. The first one is that I believe that we need a multi-institutional approach to better understand these tumors, mostly because they are rare and most hospitals only see a handful of cases a year, but also because most sex-core stromal tumor subtypes don't have any specific markers, and therefore there might be some differences in how these tumors are classified in different institutions. And the second point is whether we should consider a classification that incorporates the molecular findings in the future, at least for a subset of these tumors. For example, I believe that FH deficient sex-core stromal tumor may be a good term for the FH deficient neoplasms that we have been classifying as Leydig cell tumors, because such a classification would highlight the distinct biology and the distinct clinical behavior that these tumors seem to have, of course, provided that others can corroborate our recent findings. And that's all I have. Thank you very much, and happy to answer questions now.
Thank you, Andy. That was an excellent talk, and I can see a lot of questions coming in. And maybe I'll start off with some on Leydig cell tumors. So Dr. Ming Zhao has a question regarding the FH deficient tumors. Are there any specific morphologic features that can serve as surrogates? Dr. Zhao has suggested maybe, do you see prominent nucleoli in these cases?
So when we studied these cases, we saw that prominent nucleoli were like a feature, but the problem is that many of the aggressive Leydig cell tumors of other types also had prominent nucleoli. So it was quite hard to tell. We did not see any morphologic feature that was like a telltale that you would guess like this is an FH deficient tumor. And in fact, the first of the two FH deficient tumors that I showed had prominent nucleoli, but didn't truly have like the clear perinucleolar halos that these tumors tend to have in other locations. So I would say that no, it's hard to predict which of these tumors are going to be FH deficient just based on morphology.
That's very helpful. So if I'm understanding that, you feel that it's not a very specific morphologic finding. And to follow up on that, there's a question from Dr. Ankur Sangoi, and he has a question regarding working up Leydig cell tumors. And would you recommend screening maybe all Leydig cell tumors with markers like FH, or do you screen maybe just the more aggressive tumors?
What I'm doing now, and it was based on the study, was to test specifically the ones that have at least one or two aggressive histopathologic features. But whether, because the two cases that were published in that study that Dan Burney was part of, doesn't have any information on whether those cases had aggressive features or not. Our experience is that all of these cases had at least one or two, more than two or more, aggressive features. But whether to screen every tumor or not is a good idea remains to be answered. What I can tell you is that Fiona McLean presented in the Australasian meeting of pathology several years ago a study of 34 Leydig cell tumors without aggressive histopathologic features that they screened with FH IHC, and they did not find any case with loss of FH expression. So that's why I restricted to the aggressive cases.
So maybe for now, the recommendation would be to screen the more aggressive tumors. And I see that we're coming up to the top of the hour, and it's time for our next speaker. So thank you again, Andy. There was an excellent talk. I learned a lot. And I'll hand it off to Samson for the next speaker to introduce our next speaker.
I just echo those thoughts. Thank you, Andy. Thank you, Shonak, for the moderation. Our next speaker is Dr. Giovanna Giannico, who is a genitourinary pathologist and associate professor of pathology, microbiology, and immunology at Vanderbilt University Medical Center in Nashville, Tennessee. Giovanna serves there as the director of genitourinary pathology service and the director of their genitourinary pathology fellowship program. Her research focuses on translational aspects of GU neoplasia with an emphasis on prostate and penile cancer, and she has authored and spoken in many venues about these topics. Dr. Giannico has been a member of GUPS since its inception, first serving in the nominating committee, currently on the membership committee, and it's my pleasure to welcome Giovanna to educate us on the topic of penile intraepithelial neoplasia. Giovanna, please share your slides and begin.
Thank you, Samson, for inviting me, and thanks to those who have joined our GUPS virtual lecture today. I will discuss the 2022 updates in penile intraepithelial neoplasia. This is the most recent 2022 classification of penile neoplasia. At the outset, I would like to anticipate that after the significant changes that were made to the classification of penile neoplasia with the WHO 2016, the current 2022 updates this year were only minor. And although most of my discussion will focus on PIN, I will also briefly mention some of the changes that have been introduced with invasive penile neoplasia. These are the main changes that come with the 5th edition. There are changes in nomenclature, changes in histologic subgroupings, and changes within the tumors of the scrotum. With regards to nomenclature and for precursor lesions, such as PIN, the terminology pattern replaces now the terminology variant. For invasive carcinoma, the terminology subtype replaces again the terminology variant. And this change is actually pretty consistent across the boards in the 5th edition, with the intention of leaving the use of the term variant in reference to entities with a specific genetic alteration. With regards to histologic subgroups, in general, in penile neoplasia, the 2022 classification has significantly streamlined histologic classification, simplifying it. Now, subtypes are actually grouped into our overarching squamous cell carcinoma histology. For example, the usual type squamous cell carcinoma now includes pseudohyperplastic and acantholytic pseudoglandular carcinoma. And the carcinoma cornicularum is now included within the spectrum of verrucous carcinoma. For those complex patterns that include more than one subtype, multiple components, therefore, such as warty basaloid, the terminology is now being replaced with the use of a more genetic umbrella of mixed tumors. For example, this would be the case of a carcinoma cunicularum or verrucous carcinoma adjacent to a usual type invasive squamous cell carcinoma. WHO encourages a specification of the different subtypes when they are found together in mixed tumors, and also encourages reporting the relative percentages of these subtypes. And this slide actually shows more in details the changes between the 4th edition and the 5th edition. One thing should be said that the WHO this year not only retains, but also emphasizes the prior 2016 classification of HPV associated and HPV independent penile carcinoma. For precursor lesion, which is the topic of today's lecture, the descriptive nomenclature are complex, as I mentioned earlier, the complex patterns such as warty basaloid, they've been now replaced by the more genetic terminology of mixed. For invasive carcinoma, some complex subtypes such as papillary basaloid and warty basaloid and have now been replaced by the genetic terminology of mixed. And for non-HPV related squamous cell carcinoma, as you can see, some of the more descriptive terminology of pseudoglandular and pseudohyperplastic have been included within the umbrella squamous cell carcinoma usual type, whereas carcinoma cuniculatum is now within the spectrum of verrucous carcinoma. We also have a mixed category within HPV-independent squamous cell carcinoma. And then in addition, this is new, in addition to the two broad categories of HPV-associated squamous cell carcinoma and HPV-independent squamous cell carcinoma, we have now a third category that is that of squamous cell carcinoma NOS, which is something to be used in those settings when there is no P16 available for subclassification, for those invasive keratinizing type carcinomas without special type morphology. And the third and final change within the classification of penile neoplasia is the inclusion for the first time in the WHO classification of the tumors of the scrotum. The classification reflects that of penile cancers for both precursor lesions and squamous cell carcinoma. Now, a few words again, PIN, penile intraepithelial neoplasia, is the topic of today's discussion. So a few words on PIN. PIN is rare. There are about 0.45 cases per 100,000 described in Europe, and it has distinctive geographic distribution. We know, for example, that differentiated PIN is more frequent in countries with elevated penile cancer incidence than worthy and basaloid PIN. In fact, in this paper that is mentioned here, this was a comparative case series between Paraguay and France. Soskin et al. Demonstrated that differentiated PIN occurred in about 2/3 of cases in the Paraguayan cohort versus about 20% of cases in the French cohort. On the opposite trend, PIN with worthy and basaloid feature represented about 1/3 of cases in the Paraguayan cohort and about more than 2/3 of cases in the French cohort. PIN is viewed as a precursor lesion. In fact, this was a large study from a Paraguayan cohort from Dr. Cubilla's group that included 139 lesions from 121 patients. In this study, PIN was very frequently associated with invasive carcinoma, up to 78% of cases. As you can see, PIN, the morphology of the precursor lesion was similar to that of the invasive lesion, such as the differentiating keratinizing tumors in the PIN precursor form were accompanied by usual type papillary and pseudohyperplastic carcinomas. And for those PIN that had worthy and basaloid features, the accompanying invasive carcinoma was also the worthy basaloid and worthy basaloid carcinoma morphology, suggesting, therefore, that PIN could indeed be a precursor. In this cohort, most tumors were limited to one anatomical location, 80% of them, and they were more likely to be associated with invasive carcinoma, about 2/3 of them, and less likely to present as isolated PIN, about 1/3 of them. And among PIN cases associated with invasive carcinoma, the glands was the most frequent location, whereas among cases that presented as isolated PIN, their morphology was more likely to be differentiated in about 80% of cases and presenting in the foreskin in about 2/3 of cases. And as you know, differentiated PIN is more likely to occur in the foreskin in general. With regards to HPV DNA, this was a recent meta-analysis of 73 papers published on Lancet Oncology in 2019 in HPV-related squamous cell carcinoma. The pool HPV DNA prevalence was about 73% with a prevalence of P16 positivity of 86%. In non-HPV-related squamous cell carcinomas, about 20%, the pool HPV DNA prevalence was about 20% with a 17% of P16 positivity. And within PIN, the pool HPV DNA prevalence was about 80% with a P16 prevalence of 50%. HPV genotypes. There is some overlap in the degree of HPV genotypes that are identified with invasive cancer and precursor lesions. Within invasive cancer, The most likely high-risk genotypes are HPV 16 and 18. For low-risk genotypes, 6 and 11 prevail. In penile intraepithelial neoplasia, the most common high-risk genotypes are HPV 16 is definitely present, the most common, but also the secondly most common forms are HPV 31 and 33, and less likely HPV 18 has been identified. Whereas for low-risk morphology, for low-risk genotypes, 6 and 11 also prevail in penile intraepithelial neoplasia. We know that specific HPV genotypes are also associated with specific PIN morphologic subtypes. These are two excellent studies from Dr. Kubiya's group that have shown that PIN had greater genotype variability than invasive carcinoma. Up to 18 genotypes were identified in PIN. And this greater variability was more likely to occur in warty and multicentric PIN. In this setting, they had up to 11 different genotypes, whereas a basaloid PIN that is more likely to be unicentric as well was associated with a single genotype, usually HPV 16. And in their study, there was correspondence between the HPV genotypes identified in both the precursor and the invasive lesion. And this is the current 2022 PIN classification. I wanted to focus on PIN now. So within the HPV associated broad category, we have common patterns of PIN, basaloid, warty, and mixed. And within less frequent patterns, we have now pagetoid, clear cell, and spindle cell. And then within the differentiated category HPV independent PIN, we have differentiated PIN. A few words on penile intraepithelial neoplasia, HPV associated. This is the recommended terminology for according to WHO 2022, and the terms penile carcinoma in situ, Bowen's disease, and erythroplasia KRAT are not recommended in the 5th edition. At least in this part of the continent, HPV associated PIN represents 80% of all PIN lesions. It occurs more likely in younger patients as opposed to differentiated PIN, invasive carcinoma that occur in an older age. And they can be in a single location, as I've discussed with other manuscripts, but also they can be multifocal. Most likely occur in the glands and in patients that have history of condylomata. I would like to mention also Bowenoid populosis. That is a lesion that is HPV 16 related, that occurs in younger patients and is less likely to be aggressive. And this is most likely, this occurs in a different location. It's a multifocal lesion most of the times. And occurs on the shaft, perineal skin, and mons. And it presents with warty, red, velvety maculopapular areas. One thing that I would like to underline is that PIN is not graded and all lesions are considered high grade. And this is an example of warty PIN. You can see here that there is a thickened epithelium throughout the thickness here with an undulating, spiking surface. There can be hyperkeratosis and parakeratosis. The characteristic of this lesion is the presence of colocytosis with, as you can see, double nucleated forms, racenoid nuclei, halos, and there can be, in rare cases, prominent vacuolar changes that almost impart a clear cell appearance to the lesion. This is the morphologic pattern of P16 expression in warty PIN. You can see there is block positivity, but typically the stain is stronger at the base. And as we go towards the surface, which shows the more mature forms, the stain becomes less strong and to even become negative within the keratinizing surface. This is the basaloid morphology of PIN. You can see that the thickened epithelium is replaced by a monotonous population of small to intermediate size immature cells. There can be parakeratosis, but typically the surface is flat. Typically within the thickness of the epithelium, there are numerous mitotic figures and apoptotic bodies, almost to impart a starry sky appearance to the lesion. And the base tends to be undulating due to papillomatosis of the reedy ridges. By P16, we have a typical full block and strong P16 pattern of expression. And this is an example of what today would be called a mixed pattern, warty basaloid that typically shows a surface of warty morphology, and the base of the lesion that typically shows a more basaloid morphology. By P16 expression, you can see there is this strong and diffuse expression of the marker in the deeper portion of the lesion, whereas within the warty component of the lesion, the stain is weaker. These are higher up, close-up pictures. You can see this is the surface. Typically, this is how warty basaloid morphology presents with this surface that shows the warty component, and the base that shows these immature cells of basaloid PIN. These are other examples of mixed tumors. In this specific setting, the mixed tumor was actually due to presence of different lesions, different parts of the specimen. You can see that one portion of the specimen had a warty basaloid component. Once again, hyperkeratosis, parakeratosis, thickened epithelium, coilocytosis at the surface, basaloid immature cells at the base. And once again, P16 shows this very strong pattern of stain at the base and a lighter pattern of stain at the surface. Another portion of the specimen showed this basaloid component with these immature cells. And again, P16 has a stronger and diffuse a stronger pattern of expression. This is another example of a mixed pattern where the two lesions are almost adjacent. You can see that one side of the specimen show this papillary basaloid component. Again, the cytologies that are a basaloid tumor, but has this papillary pattern at the surface. And you can see here, again, strong P16 expression. Whereas the other section of the tumor adjacent to the papillary basaloid component harbored a warty component. Here again, you can see marked coilocytosis here. With the, again, once again, strong P16 expression at the base with a lighter expression of the surface and negative expression within the keratinizing surface. A few words on differentiated PIN, HPV independent. The WHO suggests the terminologies that I have actually just mentioned. Rather than a squamous intraepithelial lesion, rather than squamous cell carcinoma in situ, low-grade, high and high-grade dysplasia, PIN3, simplex type of PIN, this terminology is not recommended. As for HPV-associated PIN, differentiated PIN is not graded and it's always considered high-grade. As I mentioned earlier, it occurs in older patients, greater than 6-year-old. It can be uni or multifocal, and is more likely to occur on the foreskin with the white or pink plaque-like lesions. This is an example of differentiated PIN. You can see there are slight parakeratosis at the surface. There is a relatively thickened epithelium with elongated and anastomosed reedy ridges. Typically, the atypical cells will be present in the basal layer, typical basal cells and parabasal cells with hyperchromatic nuclei and increased NC ratio. There could be also whirling keratin formation in this particular morphology. And typically the lesion shows almost this acantholytic morphology, almost with these very prominent intercellular bridges. Although acantholytic is probably a little bit exaggerated, but definitely in prominent intercellular bridges can be seen. P16, as expected, should be negative in this lesion. P16, I apologize, lichen sclerosis is typically being found to be associated with differentiated PIN. In fact, in this study by Cañete Portillo et al. in Dr. Scubilla's group, PIN independent, HPV independent type was associated with lichen sclerosis in about 89% of cases. And interestingly, they found that the distribution of lichen sclerosis with the adjacent PIN follow up a specific spatial pattern distribution. The most common distribution was that of PIN that was adjacent and comprising lichen sclerosis in about 50% of cases. In less cases, 23% of cases, lichen sclerosis was adjacent to PIN. In 80% of cases, it was next to and within invasive carcinoma, and it was less likely to be present within spaced by separate normal tissue. In about a quarter of cases, PIN and lichen sclerosis were distributed in a way to show the entire spectrum of sequence of precursors to invasive carcinoma. And with regards to immunohistochemistry, we expect differentiated PIN to be P16 negative. And a relatively recent study from Shows et al. In Dr. Kubilla's group showed that Ki67 is a good marker for differentiated PIN if we would like to differentiate squamous hyperplasia from a precursor lesion. And in that setting, Ki67 shows basal and parabasal expression that is continued. This marker is, however, less of a good marker if we would like to distinguish different forms of PIN, because both HPV associated, HPV independent would be positive similarly. A few words to spend on P53, different from the cervical setting. P53 is actually an unreliable marker in PIN because it actually is variable. It can be null, it can be patchy, or it can be diffuse, suprabasal. So P53 not reliable in this differential diagnosis. So we get to the outcome. In general, given the rarity of penile tumors in general and isolated PIN in particular, the prognostic significance of PIN by itself and of its different morphologic subtype is not well known. One thing we know is that there is no prognostic or treatment difference between HPV-associated and HPV-independent penile tumors, although there are some studies that have shown that possibly HPV-associated carcinomas have a slight better outcome than HPV-independent ones, and they are more likely to respond to radiation therapy. But with regards to PIN, we don't have a lot of this information. This is why we undertook a study. This was an institutional study that collected all cases of isolated PIN. So these cases were not accompanied by an invasive tumor. And we collected 64 patients harboring 82 lesions. Most of the lesions were present in the glands, but also in the shaft and foreskin. And about a third of these lesions were located, were multicentric. Altogether, all these 64 patients collected about 110 repeated procedure. Actually, we had one patient that had up to 9 repeated procedure. And I need to specify that the treatment that these patients received was multimodal. It included different level of surgery. It included laser ablation, cryotherapy, as well as topical application of medications. We found that for excisions only, positive margin accrued to 63% of different procedures. 30% of these patients recurred, and 16% had persistent disease after treatment, whether this was local or surgical. Progression occurred in 1 of 42 patients in whom we had follow-up, so 2%. And the histology classification was not associated with odds of recurrence persistent, although in our study, we had only a few cases of differentiated PIN. However, positive margin and multifocality were associated with higher odds of recurrence and persistent. And among those 42 patients, 86% a follow-up that was at a median of 23 months. 86% of these patients were negative for disease. 12% were alive with disease, and 2%, this one patient that I've mentioned, was dead for disease. And this case of this patient that progressed was a 54-year-old Caucasian man. This patient had a biopsy that was followed by immediate local excision. And this showed HPV-associated warty basaloid and basaloid type PIN. And this excision had multiple positive margins. After 16 months, the patient recurred and he had a re-excision, as well as an excision of an inguinal mass that showed well-differentiated squamous carcinoma metastatic to left inguinal lymph nodes. The patient died after 30 months after diagnosis. So the conclusion of the study was that we did notice that there is an infrequent progression in the setting of even frequent positive margins, suggesting that PIN could remain latent for many years, may regress spontaneously. Some form could be cured or probably attenuated with various topical or local treatments. And isolated PIN may represent a unique entity, possibly dissimilar from PIN that arises de novo with invasive carcinoma. And we definitely need additional study to understand the natural history of PIN. And thank you for listening.
Thank you so much, Giovanna, for this comprehensive talk. We have a couple of questions that have come in, and so I'll phrase them to you now. The first one I'd like to ask is, given in the last WHO, the separation between HPV and non-HPV, and now that carrying over into WHO 2022. Someone asked, does the mixed pattern of penile intraepithelial neoplasia recognize the possibility of a mixture of non-HPV and HPV-associated PIN? Or is it only in HPV-associated?
Yes, it is only in HPV associated. In our paper, we did actually separated this category. We actually specify, but again, this was the terminology that we use in our paper. It was not, it is not in WHO. We actually recognize that hybrid terminology. We use the hybrid terminology to include specifically cases that were HPV associated with different morphologies, with different patterns. And we use the mixed terminology to actually include cases that were HPV associated as well as cases that were HPV independent. It is my understanding that WHO does not assess, does not include mixed cases as HPV associated as HPV independent.
Understood. Thank you. And also with regard to low-grade squamous intraepithelial lesion-like lesions, beyond condyloma, what do we do if we encounter one of these low-grade lesions in the area of the penis?
Yes, this is a very good question. And I wanted to specify that there are several morphologies. A condyloma is not just the only morphology of low-grade lesions. In fact, we can have also flat lesions, flat. They are not condylomatous. So flat, low-grade intraepithelial lesions. The idea is that rarely, but some of these forms, condylomatous lesion or flat, low-grade squamous intraepithelial lesion, may, although rarely, harbor high-grade HPV genotypes. Dr. Kubilia recognizes the word of atypical condylomas, which is something that it defines as lesions that have at least 30% atypia, that is beyond the mild atypia. And typically, there is a chance that if you did HPV genotypes, you could probably have that these will stain positively with a high-risk morphology and will actually be regionally positive for P16. So at least in my practice, when I have a condyloma, I do run at least a P16 on these because you may be surprised that more often than not, you may find some areas that may harbor higher grade areas. And in these cases, it is suggested that these patients be followed more strictly, more frequently, than patient that had just condylomatous lesions.
Great. And time for one last quick question. It's more of an epidemiologic question, so it may be outside the scope. But someone asked, does HPV, the advent of HPV vaccination in women over the past, number of years, has that been noticed epidemiologically to have an impact on the incidence of penile lesions in men?
This is a good question. We have seen the best results in countries that have adopted an epidemiological approach of widespread vaccination, such as in Australia. I am not aware, though, and I apologize if from these studies, there is a decrease in the frequency of penile intraepithelial neoplasia in men. And it would be interesting actually to know about this. So I don't know. I do know that there has been a significant decrease in countries like Australia, significant decrease of penile, cervical cancer in women that were so widespread, vaccinate is so widespread, in such a widespread pattern, such as in Australia.
Okay, thank you so much. Again, thank you for the wonderful talk, for teaching us a lot, and for expertly answering the questions. It's my pleasure now to introduce my co-host, Dr. Cristina Maggi-Galuzzi again, who's going to introduce Dr. Al-Obeidi.
Hello, everyone. Good afternoon, probably good evening, maybe someone, or good morning. It is my great pleasure to introduce our next speaker, Dr. Khalil Al-Obeidi. He earned his medical degree at the University of Dammam in Saudi Arabia in 2012, and then he started there his anatomic pathology residency soon after that. But then in 2015, he decided to move to the United States, where he pursued a pathology residency training, followed then by training on head and neck pathology, and subsequently a genitourinary pathology fellowship at Indiana University. Also, these two fellowships were followed by a molecular genetic pathology at the Cleveland Clinic, although we did not overlap, unfortunately, at the Cleveland Clinic. His major interest is in genitourinary diagnosis and research on renal neoplasm classification. And during his training at Indiana University, he has actually worked and refined the characteristic histologic features and molecular characteristic of a not very common type of tumor, but an important one, the papillary renal neoplasm with reverse polarity. And he has also done additional study to evaluate recurrent alteration in another rare tumors that occur in the kidney, the thyroid-like follicular renal cell carcinoma, where it detects the EWSR1 PADS fusion. Over the past 4 years, he has participated in numerous pathology conferences with numerous abstracts, and he has published more than 30 articles in very highly impact reviewed journals. And he also been involved in the writing of 2 book chapters, so he's been very busy. And he's currently is a staff genitourinary pathology at Henry Ford Health in Detroit, Michigan. It is my great pleasure to introduce Khalil. Please take it away and give us an update on renal tumors.
Thank you, Dr. Maggie Galazzi, for your introduction, and Dr. Fines and the GUPS committee for putting this and organizing this session. So today I'll be talking about the papillary tumors of the kidney and focusing on some of the updates that are just published in the current 2022 WHO classification system. Okay. I have nothing to disclose. The outlines for my presentation, few words about the epidemiology of renal cell carcinoma, the evolving history of renal cell carcinoma in general, and the papillary RCC in particular, and then we'll spend the bulk of time talking about the papillary renal cell carcinoma subtypes as outlined in the current classification system. Now, the kidney and the renal pelvic tumors are the 6th leading cause of new cancer diagnosis in men and the 9th in women, with an estimated incidence of 76,000 cases and a mortality that's close to 14,000 cases in 2021, according to the American Cancer Society statistics. Now, most of these tumors arises from the renal tubules and are sporadic in nature. However, it's estimated that 5 to 8% are heritable. Several risk factors have been associated with the development of renal cell carcinomas, including cigarette smoking, excess body weight, hypertension, and most importantly, familial cancer syndrome, including the VHL disease, the hereditary papillary renal cell carcinoma, the HLRCC, associated RCC or FH deficient RCC, tuberous sclerosis, and Birt-Hogg-Dubé syndrome. Now, if we look at the classification of renal cell carcinoma, the first WHO was released in 1981, and it stated that it will, of course, be appreciated that the classification reflects the present state of knowledge, and modifications are almost certain to be needed as experience accumulates. And the classification was based primarily on the microscopic characteristics of tumors, and therefore is concerned with morphologically identifiable cell types and histologic patterns as seen with light microscopy. So it's not surprising to see that the first classification system contained only adenoma and renal cell carcinoma that was further subtyped based on the cytoplasmic characteristics of cells into into clear cell and granular cell subtypes. Now, if we look at the papillary carcinomas of the kidney themselves, one of the earliest reports in this tumor was a radiologic study in 1960s where they found characteristic radiologic appearance of these tumors of like avascular or hypovascular morphology, and they included 6 cases that were diagnosed as papillary tubular adenocarcinomas, and the follow-up for these tumors ranged from benign to completely malignant clinical course. A few years later, a retrospective study looked at renal carcinomas, and they included 5 additional cases diagnosed as papillary adenocarcinomas. And again, these the follow-up for these cases ranged from benign to completely malignant clinical course. Now, the term papillary renal cell carcinoma was first used in the 1970s, and in a paper that studied the clinical radiologic and pathologic features of 34 cases and compared them to 190 cases of non-papillary tumors. And interestingly, they have found some and described some of the features that we used to associate with papillary RCC, like the cystic nature and the macrophage infiltration. And also interestingly, they found that patients with papillary tumors had better survival than patients with non-papillary tumors. So looking back at the olden days where the diagnosis of papillary renal cell carcinoma was rendered, it used to include many entities and a heterogeneous group of different subtypes, including what we now use as a conventional type papillary RCC, but also included many translocation carcinomas, tubulocystic carcinomas, some of the collecting duct carcinomas, the HLRCC, and some of the emerging entities that are lately defined, such as the biphasic hyalinizing symmomatous RCC, the papillary renal neoplasm with reverse polarity, and some of the recently recognized new entities, such as the eosinophilic solid cystic RCC. So in an attempt to clear up this mess, and one of the major effort in this regard was in 1997 by Dr. Dillahunt and Ebley, where they studied little over 100 cases of papillary RCC, and they divided them into types 1 and type 2. Now, type 1, as we know, is composed of these thin fibrovascular cores with that are covered by cells with minimal cytoplasm and have relatively uniform nuclei, while type 2 have these larger cells, larger eosinophilic cells with more higher grade nuclei. In the same year, in 1997, the UICC and AJCC held a consensus meeting, and the papillary RCC made it through into a category of papillary of the renal cell carcinoma classification. This was carried through to the 2014 classification system, and the papillary RCC was recognized as a distinct entity, and it was recognized that there are 2 types, type 1 and type 2. And this carried through to the 2016 classification system. However, many entities that were once included into the papillary RCC, namely mainly type 2, were no longer included into that subtype, such as the HLRCC, associated RCC, and many of the translocation carcinomas. And however, it was recognized in the 2016 classification system that although type 1 has a unique morphology and could be a unique tumor, type 2 represented a heterogeneous group of many tumors. And one of the most notable work in that regard was the paper published in the New England Journal of Medicine with the use of the TCGA data, and they looked at the molecular characteristics of the papillary RCC, and they found that papillary renal cell carcinoma consisted of at least 3 subtypes based on the molecular and phenotypic features. Actually, a few months ago, another paper came out and looking at 199 cases of papillary RCC, and they found it's no longer the case that type 2 had worse prognosis than type 1, and the presence of type 2 morphology in itself did not have significant impact in outcome of these patients. So based on these recent findings, the current 2022 classification system no longer recommends the subdivision of papillary renal cell carcinomas into types 1 and type 2. However, the current classification system recognizes some subtypes within the papillary RCC category, including the biphasic squamous alveolar renal cell carcinoma, the wharton-like papillary RCC, the biphasic hyalinizing psammomatous RCC, and the papillary renal neoplasm with reverse polarity. So why do we even care about all these classifications? Why we're making this big fuss about it? So the reason why we're doing this is that some of the entities that we used to recognize as papillary RCC in the early 2000s are no longer part of it because of the they have different prognosis and behavior than the usual conventional papillary RCC. While some of them have more worse prognosis, such as the FH deficient RCC. So it's important to recognize these entities as they have implications on a prognosis, and some of them may have some genetic implications as well. So we'll start talking about these subtypes within the current classification system, and the first one of which is the biphasic squamous and alveolar RCC. And this entity was published first in 2012 in a series of 2 cases, one in men and one in women, with a size of 3 and 3.7 cm, and they both had benign clinical course. On low power, they have solid morphology and architecture. However, going in high power, you can appreciate the biphasic nature of this tumor, where you have a more larger cells, eosinophilic cells in the center, and surrounded by these smaller cells around them. Many areas you can appreciate some imperiopoiesis and focal areas of oncocytoma-like features. And importantly, these tumors stain similar to conventional papillary renal cell carcinomas, where they are positive for PAX8, keratin 7, Amicar, and Vimentin. And a recent study that's published in the Modern Pathology looked at MET alterations. And as we know, MET alteration is highly specific to papillary renal cell carcinomas, and they included 17 tumors, and one of their patients died of disease. And they found that MET alterations occurred in 54% of that series. And that supports the idea that this biphasic squamous alveolar papillary RCC likely represents a subtype or a variant morphology of papillary renal cell carcinoma. The second subtype is the wharton-like papillary renal cell carcinoma, and this subtype was published in 2017, seniored by Dr. Andre Hess. And in a study of 11 tumors, mostly in men, most of them had benign clinical course. However, up to 1/3 died of disease. And these tumors had papillary architecture and covered with eosinophilic cells. And the characteristic feature that was highlighted in all of these tumors was the presence of intense inflammatory cell infiltrates within and surrounding the tumor, resembling that seen in the wharton tumors of the salivary glands. These tumors stain in a similar fashion to the conventional papillary RCC, where they are positive for Amicar and Vimentin, and one of their tumors showed polysomy of chromosome 7 and 17, supporting the idea that this likely represents a subtype of papillary renal cell carcinoma rather than a distinct subtype. And unfortunately, no other reports from any other institutions have found this morphology. So it's only the 11 cases reported in 2017. The third entity is the biphasic hyalinizing psammomatous renal cell carcinoma, and this entity was reported by Dr. Organi from Hopkins 2 years ago, and they had reported 8 tumors range in size from 1 to 7 cm, and most of these tumors were from the consultation archives, so they had limited follow-up. However, one of the patients had died of disease with bone and lung metastases. Morphologically, these tumors appeared nodular and rounded, and all tumors had solid growth and mixed with papillary architecture, while one of them had was admixed with tubular morphology. Again, and all of these tumors had biphasic cells. However, in contrast to the biphasic alveolar and squamoid, the smaller cells were within these cystic spaces, and these were surrounded by the larger eosinophilic cells with some areas of clear cytoplasm. And the smaller cells were almost always surrounding these hyaline globules, and there were a lot of areas with the glomeruloid appearance. And as the name states, the biphasic, you have the two different types of cells and symptomatoid, extensive symptomatous calcifications in all of the tumors, and hyalinizing with the designating the presence of extensive hyalinization in these tumors. On immunohistochemistry, all the tumors were positive for PAX8, keratin 7, and HNF1 beta. However, they were negative for GATA3, cathepsin K, melan A to help excluding the translocation carcinomas, and they were negative for inhibin, SF1, and WT1 to help excluding some other metastatic tumors. And interestingly, all these tumors, all 8 tumors had an F2 pathogenic or likely pathogenic mutations in them. And in a recent study, AJSP study that looked at the NF2 mutated renal cell carcinomas and included 14 tumors, 10 of them had aggressive clinical course. However, not all of the tumors that had NF2 mutations had similar morphology to the biphasic hyalinizing symptomatous RCC, although many of them had similar features. Again, the biphasic nature was not present in all tumors. The sclerosis was not present on all of them, so suggesting that the NF mutation is not specific to the biphasic hyalinizing symptomatous RCC. Again, in the recent study, the tumors they included were positive for stains that were similar to the papillary RCC for including the Emacar, Vimentin, keratin 7, but most importantly, they were negative for translocation carcinoma markers, and they were negative for they showed retained FH staining as well, which helps exclude the FH deficient RCC. The last subtype or the emerging entity in the WHO classification system is the papillary renal neoplasm with reverse polarity. And if we look at the first papers that looked into this entity, and I found a picture in the first WHO classification system in the 1981. And again, if we go back in history, in 1997, Dr. Dillahunt and Ebley classified the papillary RCC into types 1 and type 2. However, a few years later, Alori et al. Found a subset of type 2 tumors that had better prognosis and called them oncocytoid type papillary RCC. In 2005, Lefebvre et al. From the same group reported 10 more tumors and changed the terminology into oncocytic papillary RCC. And in 2006, Dr. Honoré Hess reported 12 additional tumors with the terminology of oncocytic papillary RCC. And this was carried on year after year until 2017, when Dr. Rula Salib had published a paper looking at 124 cases of papillary RCC and suggested and proposed the classifying papillary RCCs into 4 types and called these papillary RCC type 4/oncocytic oncocytic low grade based on the immunohistochemical and molecular characteristics. Now, if we go back and look at all the studies from 2005 until the 2017 by Dr. Salib, we can see that some of these published tumors had unique morphology where they are formed by these thin fibrovascular cores, and they are lined by eosinophilic cells with nuclei that are lined away from the basement membranes. So in an attempt to study this specific morphology, we gathered 18 tumors And interestingly, all of them had smaller size with a mean size of 1.6 cm, and the larger tumor we had was 3 cm. All of these tumors had low ISUB WHO grade group, and all of them were having lower stage. And these tumors, most of them were encapsulated, and many were not encapsulated. However, they were all formed of these arborizing papillae and covered by eosinophilic cells. And characteristically, the cells having nuclei that are aligned away from the basement membrane at the apical surface, hence called the reverse polarity. And again, all the nuclei, as we can see here, are monotonous and with no areas of overlapping, with the frequent nuclear clearing. These tumors were consistent or are consistently positive for GATA3 and IL-1 in a cup-shaped fashion, and are negative for Vimentin and Emicar. Other less common pathologic features includes the predominant of tubular architecture, edematous papillary cores, focal cytoplasmic clearing, and focal nuclear hub-nailing. So in the original study, we compared these tumors to conventional type 1 and type 2 papillary renal cell carcinomas, and we found that they stain consistently positive for GATA3 and IL-1, which is the opposite for the conventional types 1 and type 2, and the opposite is truth for Vimentin and Emicar, where the conventional types are positive and these are usually negative, except for Emicar, it's usually negative, but sometimes can show some positive staining, and it's usually in a blush-like pattern, not a strong positive staining. So we attempted at studying these further. So we had 10 tumors with sufficient material. So we did next generation sequencing. And interestingly, at that time, we found that 9 of the 10 tumors had mutations in the KRAS pathway, 8 with KRAS mutations, and 1 with BRAF mutation, and none of the 30 papillary renal cell carcinomas in the control group had KRAS mutations. We did clustering, mRNA suppression and clustering analysis, and they clustered in a different way than the other papillary renal cell carcinomas. And a few months later, Dr. Kim and his colleagues reported 30 tumors of papillary renal neoplasm with the reverse polarity, and found the KRAS mutation in 93% of cases, and none of the 49 tumors in their control group had KRAS mutation, further supporting the unique recurrent KRAS mutation in these tumors. A recent paper that reported 7 cases and reviewed 93 cases in the literature, the incidence or the rate of KRAS mutation was found to be 85%, and more importantly, there was no adverse pathologic events in the 100 tumors reported within with a mean follow-up of 31 months and median of 49 months. Again, a few months ago, we published a paper looking at these lesions, and we found some tiny lesions that measured less than 1 millimeter and that were incidental in the kidney. And we found that the KRAS mutation present in lesion as small as 0.6 millimeter, supporting the idea that the KRAS mutations are early events in the development of renal cell carcinomas. So in summary, I would end with the statement from the 1981 classification system. It will, of course, be appreciated that the current classification reflects the present state of knowledge, and modifications are almost certain to be needed as experience accumulates. With that being said, thank you so much. This is my my mentor, Dr. David Agrinian, who passed away a few months ago and helped me with a lot of my projects. And these are my 2 little ones. And I would welcome any questions.
Thank you very much. This was a fantastic presentation and review of all these papillary tumors. I'm sure that all the audience appreciated some of these clarifications, since there are so many new entities coming on board on a daily basis. One of the questions on the chat is now, if what do you recommend to sign out some of these emerging subtypes if you don't have access or the capability to perform molecular studies?
So that's a very good question, actually. So some of the subtypes, for example, so top line is, if you know it's papillary adenosine carcinoma, top line would be papillary adenosine carcinoma. However, some of the entities like the papillary renal neoplasm with reverse polarity, it has distinct morphology. You didn't need to go for molecular studies. GATA3 is widely used, so you can just do GATA3 again, and you will reach diagnosis. For the biphasic submomentous hyalinizing RCC, there's still unique morphology to it, and if you have like a good morphology, you can probably put it in the note. You top line it as papillary renal cell carcinoma, and in the comment you can say that what we use to see, what we are saying is, what we are doing is that, well, this morphology has been reported recently in tumors such and such. However, these are reported to have NF2 mutations, and we still, and you can reference the WHO classification system, and we're waiting for further studies to support whether or not this is a distinct entity. So yeah, we still know we're not close to the time of applying the molecular classification into these papillary renal tumors, and many of them we don't still recommend the molecular studies, except the molecularly defined entities in the WHO classification system. So yeah, if you have a unique, like the typical morphology of the tumor, you can top line it as papillary RCC or the subtype itself, and in the comment you can add the WHO classification, the current recommendation by the WHO classification system.
So in terms of treatment, is there anything different? So are these tumors, these entities that you described, treated differently than other papillary tumors, like conventionally papillary renal cell carcinoma type 1?
So it's usually, so that's a tricky question. Now for some tumors that, so the slide that I showed, why we are doing the classification system, many of these tumors have different prognostication. So if you say, I studied, for example, the papillary renal neoplasm with reverse polarity extensively, and so far in like over 150 cases, there is no adverse pathologic events. So it's important to recognize this entity and report it and educate the clinicians about this entity, because and instead of like, if you have it in biopsy and in a like typical morphology, and instead of going to aggressive treatment with no other justifications, you can just end up with partial nephrectomy, let's say, and clinical follow-up. But if you have morphologies that are similar to the biphasic hyalinizing submomentous, you would know that many of these tumors have aggressive clinical behavior, and that should alert the clinicians as well that these behave aggressively, and probably more aggressive than the conventional type papillary renal cell carcinoma.
I think we have time for one more question. So often, one of the questions say, often I see biphasic type features in a typical papillary renal cell carcinoma. Should we document focal features or quantitate them? Any specific immunostains that you would recommend?
By different or biphasic types, you mean, I'm not sure, is it types 1 admixed with others, or?
I was wondering myself, I don't know if there's any additional specification. Maybe is features of type 1 and type 2 present in the same tumors, but it says type 1.
Yeah, so again, as in the current WHO classification system, if you have different, it's not uncommon to see some admixed morphologies of type 1 and type 2 in the same tumor. And again, the current WHO classification system does no longer recommend subtyping them into different subtypes because they don't differ in a prognosis.
But I believe that probably whoever answered the question was focusing on type 1. So just maybe some areas where you can have the biphasic appearance, maybe be only focal. Is there any special stains That's how I interpret the question. That could help.
Not really. They are mostly stains the similar fashion to type 1 to conventional papillary cell carcinomas. I usually like Amicar diffuse staining. Sometimes Vimentin helps when it's diffuse staining. And in type 1, actually CK7 is also very helpful in that regard. Now in type 2, what used to be called type 2, CK7 probably not as much of help, but in type 1 morphology, it's very helpful.
Thank you very much. I think we're at the top of the hour. So Samson, I think.
Yes, thank you so much to all of our speakers today, to Dr. Acosta, to Dr. Giannico, and for that last talk to Dr. Al-Obeidi, as well as to my co-host, Dr. Gupta, and Dr. Majid Galuzzi. For those who have colleagues who were unable to catch this live, we hope that the recording of this will be available in the near future on the GUPS website. And we thank you all for joining us. I would just ask the moderators and the speakers to stay on for one more moment. Thank you very much.
Thank you, everyone.
Just going to give it one moment to let people leave, and then we're going to take a picture.
I took one, Samson, but you probably are more high tech.
Okay, if everybody can look right at their camera.
Should I take my headphones off because they are massive?
Yeah, it's okay. Whatever you like. I'm going to keep mine on. Whatever you like. Thank you very much. Here we go. 1, 2, 3. Excellent. Thank you so much, everyone.
Thank
Have a
you
great
for
day.
organizing this.
Yeah.
Excellent.
very
Thank
much.
you.
Great
Have a
talk,
wonderful
sir.
day. Thank you
Bye-bye.
for
See you
excellent
soon.
talks. Be
Bye-bye.
well.
Bye-bye.
Bye.
Bye.